This conference will now be recorded.
Where the heart is not reacting, the use of IMP is not very useful. Secondly, if the patient's rhythm is abnormal, which in fast or recurrent VT is going on, there is the IBP is not being cardiac output. In those patients, we have to go for any other mechanical present
This
in this
conference
webinar.
will now be recorded.
Yeah, so I want to just start this VA ECMO in cardiac setup, cardiac ECMO as this thing with this case, because we have to show how this VA ECMO we are giving in need with the cardiac acute cardiac shock. So this is a case with acute right ventricular MI. He actually came to us, came to another hospital with acute infraval MI with some RV involvement. And they have attempted primary angioplasty, but they could not engage the RCA origin. So meanwhile, they became hypotensive, went to shock, started on NORAD with a pH of 7.11 with cold peripheries. What Dr. Dipanjan told, all the features of cardiogenic shock was there. So shifted to us in steep inotropes with 18 hours of MI and obvious features of cardiogenic shock, and urine output started going down with the AKI. Had a sudden bradycardia with hypotension, intubated and ventilated, still hypotensive with lactic acidosis. So that was the echo finding of the patient because you can see the RV is full and you can see hardly any TAPC is there. So look at the RV, only the apical part is moving and the other areas are just stand still over there. And you can see the hardly any TAPC is there on the right ventricular free wall. So obviously this is a there was a previous slide which is shown by Dr. Panjan that now this kind of scenario with low pressure, hardly any ejections, you have these four options. You can go for a direct RV bypass with some Impella or Tandem Heart or Protect Duo, or you can go for an veno-arterial ECMO, which is for this patient, it's an indirect RV bypass. So what we have done, this kind of scenarios are very good for your peripheral veno-arterial ECMO in this kind of acute cardiogenic shock. So you go for a femorofemoral percutaneous veno-arterial ECMO. You put obviously we know that we put a femoral venous drainage cannula, which is going up to the right atrium and draining the blood and pushing the blood, red blood to the same femoral artery or the contralateral femoral artery with a veno-arterial support, and just give some distal perfusion to your limb which is cannulated. So with that thing, we achieved a flow of 3.28, which is almost 60 to 70% of the total cardiac output. We tried to maintain some amount of ejection throughout the period because it's RVMI. We need some ejection through in the monitor. And after putting those cannulas, because we are in hurry, we have seen we have put this NIRS on the lip. So it shows some low perfusion in the cannulated limb. So we changed our femoral distal perfusion cannula, or you put a femoral distal perfusion cannula to put a distal to supply the distal limb, and after that, actually, after taking the distal perfusion, you can see some distal perfusion is there in your limb. You can see it's your Doppler, and immediately there is an improvement in your NIRS of the affected limb. So this distal perfusion is also important for some patients where you are cannulating for cardiac ECMO. So I'm going to that, and after that, what adequacy of tissue perfusion you have to maintain in your during your veno-arterial in cardiac ECMO is different. Like you have to measure your urine output. You have to see the lactate is going up or it's going down, or you have to see the SCO2 or SVO2. So this was the patient on day 3. His lung started getting wet. So he has starting coming down on the saturation because we put our saturation probe at the right hand, and which shows some amount of North-South syndrome and with the increased amount of ejections because the lungs were getting tight and it is not oxygenating the base of the coronaries or base of the heart. So we did, and at that time also we did some CT angiogram just to demonstrate there is a Harlequin syndrome. You can see that your ECMO flow is actually reaching just up to the left subclavian base of the left subclavian, not up to your base of the heart or where the coronaries origin from this. So this is a classical Harlequin because it's a femoral peripheral femoral ECMO. The flow is actually going up to the base of your left subclavian, and after that it is actually the other ejections from the heart which is taking place, and there is a zone of conflict between two flow, that is one from the ECMO flow and the other from the flow from the heart. So there is a Harlequin phenomena, and the patient shows a saturation dropped up to 88. Actually, up to 85 it is acceptable, so we didn't change it to the combined ECMO. We just increased our ventilator FiO2, did some negative balance to the patient, and it actually improved. On the day 6 of ECMO, we started the Millinone and touch of NORAD. You can see a marked change in the ventricular contractility, which shows some amount of improvement in the ejections. So we started coming down, and as in previous webinars we have seen how do weaning from the veno-arterial ECMO on cardiac support. We look after mainly the hepatic function has to be improved before start any kind of weaning, because renals, it is not necessary to wait for recovery because you can still continue on renal replacement therapy, but before you come down on ECMO. That is our primary thing. So we give at least 48 to 72 hours for every veno-arterial ECMO in cardiac patients because the damaged organs need some time, mainly the liver and guts to recover, except in poisoning. Some poisoning require less than support. So whenever we wean the patients, what we do is we look at the compatibility of the myocardial recovery, the contractility has improved, or it's a map has improved, or it's showing any pulsatile arterial waveform, lactate less than 2, and your lung is doing fine, PO2 FiO2 is more than 200, and you look at some echo findings like ejection fraction, it has to be improved, it has to be at least 25 to 30%. Aortic VTI, we put a Doppler at the level of aortic valve and LVOT. We just take out this velocity time integral, how much blood is crossing the aortic valve, this aortic valve, and it measures if it is more than 10 or 12, and for the right ventricle it has to be, the TAPC has to be more than 12. So then with this kind of improvements, you start the patient on weaning, and obviously you put a bridge before weaning any veno-arterial ECMO, and that is your, and weaning actually it's an echo continuous echo process. Two people are there, one comes down on the flow and one continuously see the echo. With the aortic VTI, LV ejection fraction, TAPC, ECMO flow is dropped 0.3 to 0.5 liter per increments with 5 minutes at the time, and flows are reduced to 1 to 1.5 liter per minute. And you look at your hemodynamics like mean arterial pressure, heart rate, CVP, or PA, or saturation. So always you check your aortic valve VTI for that, and if you want to predict the success of your ECMO, it has to be the VTI more than 10 or 12, or ejection fraction 20 to 25%. And when you stop weaning, if you come down on the flow, and if you see the map drops by 40 or CVP rises by 20, and or the oxygen saturation drops by to 80%, as a result, you have to abandon that weaning. So obviously, and you have to keep in mind there's a good data for that, because most of the time these refractory cardiogenic shock patients are successfully weaned from ECMO in a very variable pattern. Like the percentage is starting from 30% to 76%, but even after weaning, out of that 20 to 65% patients are not survivable to discharge. They die because of some other reasons that we have to keep in mind before prognosticating any veno-arterial ECMO for cardiogenic shock patients.
तो पहला वाला जो है ना टेमिकाइड सुबह रात को है, हाँ, ये मेटाफर आपने बोला कि 2 टाइम करना, हाँ 2 टाइम करना, तो भी सुबह रात को करना, तो दोपहर को कोई नहीं रहेगा, हाँ. So this is our patient which goes for a rehab follow-up now, and so after that I'm coming down to my basic lecture for that. This is
आपको दो
आपको देने
रात
रात को
ये
लेने
रात की हो गई
होगी रात
हाँ फिर कल सुबह देना है
सर तो कितने दिन चालू रखें?
एक बीच में एक महीना चालू रखो फिर देखते हैं
This
For a
conference will
cardiac
now be
ECMO,
recorded.
sir, are you audible?
लेकिन इसके कुछ होता है
Am I audible, sir?
दवाई से
Anybody there? कोना जो उठेगा जो
दवाई लो अभी ले लो और रात को दोनों को ले लेना और रिपिन आपसे रहो और रिपिन
Yes, sir, you are audible.
Yeah, thank you. Hello, sir. So, for a cardiac ECMO, you get the different scenarios for in some different patients. Like we just came into 4 scenarios, like a peri-op myocardial infarction in a left disease. When you are unable to come off CPB, it happens inside the OT. In a case where massive pulmonary embolism with recurrent cardiac arrest, well thrombolysis, or a post-cardiac arrest sequelae with extensive peripheral vascular disease, or a stuck mitral valve with a low cardiac output. So these kind of 4 scenarios, it needs different type of cannulation. Like a peri-op MI in the OT or left main disease, unable to come off CPB, you continue that venoarterial ECMO on the central cannulations. Like you cannulate your aorta and you cannulate your RA and you vent the heart. You can vent it from pulmonary artery. But for a massive P, which is in your regular ITU, with recurrent cardiac arrest following a failed thrombolysis, you have to again rely on your peripheral venoarterial ECMO to support the circulation. And this is the case where even with the post-cardiac arrest sequelae, because of your femorals are not small, you have to shift your arterial cannula to the axilla. So this is where a post-cardiac arrest sequelae is extensive peripheral vascular disease. And this is another case where stuck mitral valve with a cardiogenic shock, again you have to utilize the patient with peripheral venoarterial ECMO, and then after the correction of your metabolic parameters, you go for a redo mitral valve replacement. So cannulations are most important in your when you are doing it, and obviously you do check your cannula positions by echo or by X-ray. Obviously, in cardiac ECMO, the cannula site bleeding or injury is much more common than your venovenous or your respiratory ECMO. And after that, after patient on ECMO, you have to see your it's adequately tissue perfusion is going on or not. But the most common thing we measure is the urine output has to be more than 1 ml per kg per hour, or your its back rate is going down or not, or sometimes we see your mixed venous saturation or your this SVC saturation is going, and you have to maintain a target SCT of 180 to 200 or maybe 160 to 180 with a PTT of 1.25 to 2 times. In venoarterial ECMO, the problems is there. This is peripheral venoarterial ECMO. It is always a retrograde flow, and whether the cerebral circulation is adequate or not always remain a question. So usual trend is just to monitor your cerebral circulation, and you prefer to use the NIRS for this monitoring of your cerebral circulation. And these 4 things can happen to your cardiac ECMO when you are running these patients are on VA ECMO, starting with the limb ischemia. Second is the LV dilatation and pulmonary edema with maybe cardiac tamponade and upper body hypoxia. Limb ischemia presents with like you can monitor your limb, like measure and report the bilateral diameter, and if it has now become mandatory to put a distal perfusion cannula, if you are putting a peripheral venoarterial ECMO, you just cannulate your the same limb towards the distal end and just put at least 7 to 8 French feet so that you can connect it with your parent circuit to perfuse the distal limb. After that, obviously you check your distal perfusion, what I've seen earlier also, whether this is perfusing or not. It is actually a linear waveform because the flow comes from your ECMO flow. Obviously, and after that you have to optimize your flow during the ECMO, that is by decreasing flow. If you have to exclude any hypovolemia is there or not, you have to exclude any bad cannula positioning, or is there any kinking is there or not, or too much of vasoconstriction, you have to come down on the vasoconstrictors whenever you have put the patient on venoarterial ECMO. Is there any kinking or not, or by increasing the flow, you can increase the vasodilatation or improving the venous cannula position. So these are the very common things with other ECMO. And optimize your map between 60 to 80, because sometimes it happens because of the vasodilatory effects of sedatives or hypovolemia from the bleeding, or it's a sepsis, distributed shock, or a postoperative vasoplegia. Sometimes this map is not so easy to maintain at around 60 to 80. So after that, the most important part of the scenario is your pulsatility. We always want some kind of pulsatility whenever we put them on venoarterial ECMO. So our target pulse pressure should be more than 10 to 20. What actually pulsatility told us? It tells us that aortic valve is actually opening on a regular pulses, and it is preventing your left ventricular aortic clot to happen. It is preventing the LV distension to happen, and it is preventing that mitral regurgitation to come down. And if we have a loss of pulsatility, what are the causes? As because this flow is retrograde, your poor heart is not able to handle that retrograde flow. So it actually goes down and showing your loss of pulsatility. Or it may happen that you are giving excessive venoarterial flow, so that your heart is getting too much of resistance to pump out, or you have inadequate preload in the system, the volume is very low, or you have a biventricular failure. The RV failure is also associated. So the different managements of this increasing pulsatility, sometimes we give some kind of inotropes even on venoarterial ECMO just to improve some native myocardial function, so that maintain some pulsatility. Sometimes you need to unload the LV also with vasodilator, or you concomitantly put IABP or Impella to go for a venting of your LV or LA, or you put an atrial septostomy so that the blood flows from left side to right side. It can vent the LV. Or you, last but not the least, it will come down on your venoarterial ECMO flow. And your target pulse pressure should be ideally more than 20, but more than 10 to 20 is fine when your Neo ECMO is running. And you can see there is a very classic picture where you can see that hardly any movement of your aortic valve with each pulse. So what is happening? And you can see the monitor, there is hardly any pulsatility. So it's a concomitant picture, what is happening inside the heart and what is you can see your monitor. So the LV is getting dilated and distended with no aortic valve opening. As a result, what is happening? The LV is getting progressive distension. It's getting progressively distended in a peripheral venoarterial ECMO in a case of poorly contracting myocardium. And then you get a severely this kind of X-ray because of the severe increase in left atrial pressure because of this mitral regurgitation and all this. And to get this kind of X-rays in the patients of venoarterial ECMO, and the blood or froth will be coming out of your endotracheal tube. And this is more frightening part of your story, but this kind of echo you can see with the stasis at the level of the aortic valve shows large clot inside the left ventricle and at the level of the aortic valve, which pushes times to the brain with 1 or 2 contractions.
अच्छा चलो ठीक है तो बाकी अच्छा.
So there is a very good paper from Mini et al. Which tells us that how to assess your LV overload on venoarterial ECMO through arterial line, CVP, echo, and wedge pressure, chest X-ray. And obviously, how do you manage it? Commonly, it is IABP. It gives some kind of pulsatility, or you can create a large PFO, but normally it doesn't help with the LV distension. If the LA pressure is very much high, only the FO helps. And sometimes transceptor LA venting and take out the blood from LA, or we have innovated one technique with the Mullen sheath through from the vein, which takes out the blood and we connect it to the venous inflow. And this baby in venoarterial ECMO, we actually vented the heart by a transapical vent. It went through left thoracotomy to vent the LV. And after that, you can put Impella or LVAD, because we don't have much experience on these two. This is the ultimate management of the LV distension on ECMO. Coming to the next part of the thing is the Harlequin. Everybody knows, I think, about the Harlequin. It's a upper body hypoxia, because your native blood, which is going to the base of the heart, supplying the coronaries and the blood vessels, are blue because of your bad lung. So obviously, your the management is how can you detect it? Your right hand saturation goes down with the increase in improving in the heart. What are the treatment options? Sometimes it is manageable with only increasing FiO2. Sometimes it is you have to shift your peripheral cannula or femoral arterial cannula to your central artery, like right subclavian artery or ascending aorta, or you change over to a central venoarterial ECMO, or you go for a unique combined kind of ECMO, which is known as VAV, where additional return cannula be inserted in the right IJV, so that with the Y connection from the femoral arterial cannula, so that some amount of oxygenated blood goes to your base of the heart. So this is a triple cannulation strategy. You can see the saturation is down with venoarterial ECMO with a good amount of injections. And what we have done, we have just done a Y from a venoarterial circuit, arterial outflow, and we have taken it a limb right IJV. So this is a case of venoarterial ECMO. This is a return cannula. Part of the cannula goes to the right IJV. This is the Y connection. One is going to your artery and one is going to your right IJV. So this is a VAV mode of ECMO. So obviously, I previously told you the hepatic function has to be improved before the weaning of the venoarterial ECMO, and you have to give adequate mean arterial pressure, pulsatile form, lactate less than 2 before coming down on venoarterial ECMO. And bridge is also essential for that, as I have earlier also shown you. And thank you. If any query, I'm ready to share with you.
This conference will now be recorded.
Next. Dr. Oja, next. So you can see the position of the diaphragm in an adult and in the pediatric patient. The left one is in the adult and the right X-ray is in an infant. And you can see the position of the diaphragm, the angle between the vertical line and the cardiophrenic angle. See how acute it is and how obtuse in the pediatric patient. And that reduces the efficiency of the diaphragm. Next. So many causes are there, and especially in a cardiac patient, we should always look for the phrenic nerve injury, and then because of trauma, neuromuscular disorders, especially in Guillain-Barré syndrome, we can have diaphragmatic involvement, and that will prolong the duration of treatment and the duration of stay in the ICU. Critical neuropathy, again, it is an entity which will affect the peripheral muscles as well as the diaphragm. So whenever you are assessing a patient for the critical care neuropathy, always get the assessment of the diaphragm either by the nerve conduction studies of the phrenic nerve or by using the eddy currents. Severe malnutrition in our country, again, because of the diffuse muscular dystrophy, the diaphragm may also get involved, and any patient who has increased abdominal pressure can also have diaphragm dysfunction and can lead to respiratory failure. Intercostal muscles again are very important, especially in cases of malnutrition. These are atrophied or dystrophied, so that is why they can lead to respiratory failure. Next. So the accessory muscles, there are many accessory muscles for the inspiration and expiration, and the list is there. You can see it on the slides. Next. So the muscle dysfunction can occur because of the overuse, that is exhaustion, because of the lung diseases, parenchymal diseases, airway obstructions like asthma, then inadequate perfusion because of shock state, hypoxemia, or because of the electrolyte imbalance, especially hypokalemia and hypomagnesemia, and tetanus and hypocalcemia are other causes. Next. So failure of breathing can occur because of the chest problem, chest deformities, foreign body in the airways, pneumothorax, or because of diaphragm problems. Next. So abnormalities of gas exchange again can be the cause for the respiratory failure. That can be because of the muscle exhaustion, because of increased effort, patient is getting exhausted, or there is an impaired gas exchange at the alveolar level because of so many causes like pneumonia and bronchiolitis and atelectasis and interstitial lung diseases. So this all we have to keep in mind when we are looking at the alveolar causes. Next. So this is what it is. When there is a pneumonia, there is a alveoli fluid filled, so that gas exchange is not occurring. VQ mismatching is there, and there is that leads to hypoxemia and respiratory failure. Next. So this you can see a patient of ILD. You can see the lung architecture is destroyed. You can see hyperinflated lung or air trapping in some places. There's a diffuse ground glassing, and there's some thickening, and there's thickening of the alveolar septae also. Next. Next. This is, you can recognize pneumothorax causing lung compression, and this is the cause, or there is a effusion. Now, upper airway disorders are very, very important in pediatric patients, especially supraglottic obstructions, and the common causes are foreign body and infections like retropharyngeal abscess, parapharyngeal abscesses, or the allergic disorders like angioneurotic edema. So any child who has respiratory distress and you think it is respiratory failure, and there is there's a lot of drooling from the mouth, the patient is unable to swallow, always think of upper airway problems, especially infections in the presence of fever. And then the laryngeal disorders like laryngeal malformations. Laryngomalacia is very common in pediatric patients. Severe laryngomalacia can cause or laryngeal cysts can cause upper airway obstruction and respiratory failure. Subglottic diseases, especially subglottic stenosis in post-extubation state, is a very, very common phenomenon in pediatric patients. After extubation, you find the child is still having distress, and the child still has sometimes many of them will have distress. This is X-ray. You can see there's a one X-ray showing a huge collection in the prevertebral space, and this is at different stages of paravertebral or retropharyngeal abscesses. Next. Okay, can you recognize the disorder? Now, go to the previous one, Dr. Saab. Go to the previous one. The previous X-ray, yeah, this is where you can see, it's again a common disorder, don't see in the adults. This is a huge enlargement of the adenoids. And the second one, you can recognize a large tonsil is hanging in the supraglottic area. So these are the common causes for respiratory distress in the pediatric and the respiratory failure in the pediatric patients. Next. Next. Now the airway, again, the common causes are the asthma and bronchiolitis and the laryngotracheal bronchitis in the pediatric patients. And the presentations are again distress with or without stridor, or audible wheeze may be there. Next. Then the abnormalities of the oxygen delivery or demands. A common one is the shock in pediatric patients. Pulmonary embolism is not that common in pediatric patients. Congestive heart failure is common. Severe anemia in malnourished child is itself is a cause for the respiratory failure. And occasionally, not occasionally, but quite frequently, we see methemoglobinemia after ingestion of some poisons in the pediatric patients. Then this is again, the shock can be because of sepsis or there's another cause for the cyanide poisoning, mitochondrial disorders. All this will lead to poor tissue tissue uptake of oxygen. Next. No. Yes. Next. So there are compensatory phenomena like tachypnea is a compensatory phenomena. Body is trying to maintain the oxygenation and clear the carbon dioxide with the use of accessory muscles. Paradoxical breathing may be there. There may be grunting. That is one of the ways the children, they increase the FRC and they recruit the lung. And there are neck is extended. Many children who have upper airway obstruction, especially supraglottic obstruction, they will have neck extended so as to open the obstructed airway. Next. So there is an increase in the respiratory drive, especially in patients who have intact cerebral and the peripheral central chemoreceptors. There is a stimulation of the pulmonary stretch receptors, so increases the muscle effort and recruitment of the accessory muscles. There is shifting of the oxygen dissociation curve. So all these are the physiological compensations that body tries to do to maintain the internal value. Next. So respiratory insufficiency we can see in patients with the severe distress. They can be depressed. They can be neurologically altered sensorium may be there. They can have grunting, altered sensorium, and irregular or gasping type of effort. So our endeavor should be to recognize these patients in the early stage, in the tachypnea stage, and before they go into the gasping stage. So these are the two types, but you all know about it: hypoxemic respiratory failure and the hypercarbic respiratory failure, type 1 and type 2. Next. So in hypoxemic respiratory failure, physiologically there is a severe ventilation perfusion mismatching is there, diffusion defect may occur, right to left shunting is occurring. So acute hypoxemic failure ultimately results in the acute life threatening and can lead to multi-organ hypoxemia, dysoxia and hypoxemia, and can lead to multi-organ failure. Next. So these are the certain cutoffs to classify mild hypoxemia, moderate hypoxemia, and severe hypoxemia, depending on the PaO2 and the saturations. Next. So management is first and the foremost, most important is the prompt recognition of these patients. So, we start using immediately. We start with the supplement oxygen therapy. We try to maintain the airway, especially in the obstructive airway diseases, and we need to maintain the ventilatory support. Next. So we always look for apneas. So if there is apnea, then we have to intubate the patient. If there is a ventilatory failure, that is hypoxemia with hypercarbia, we should ventilate these patients. So all these indications for ventilation support are based on the clinical assessment, and there is no need to have blood gases before you start the ventilatory support in these patients. Next. So these are the blood gas criteria. You know the normal values and the critical values, especially the pH less than 7.25. The PO2s are less than 70 with supplement oxygen more than 60%. And then there are certain ratios like PF ratios. All these are important if you have the blood gases. But I again stress that we should start intervention based on the clinical management. The different supports are available. We have non-invasive supports available. We have invasive supports available. So non-invasive, these days we are using non-invasive ventilation in acute stage and or the high flow nasal cannulas. And then in invasive, we have conventional mechanical ventilation or high frequency oscillation ventilation. Next. So high flow nasal cannula, we know this is heated, humidified, blended air oxygen mixture which is delivered at a higher rate, more than 2 liters per minute through the nasal prongs in patients. So what we are doing basically, we are giving humidified oxygen and heated oxygen. So that improves the flow of oxygen and the comfort of the patient. Next. So these are the basic equipment you see. We need a blender, we need a humidifier, and we need the special cannulas to provide nasal cannulas to provide oxygen, heated humidified oxygen to the patient. Next, 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 next. So these are some of the mechanisms, suggested mechanisms, because it reduces the work of breathing, because of the reduction in the inspiratory resistance imposed by the upper airway. Then there is a washout of the nasopharyngeal dead space. There's improvement in the lung compliance because of the humidified gases are available to the patient. And then there is some distending pressure. We really don't know. Remember, the HFNC and NIV are the non-invasive ventilation are based on different principles. So here what we are using flows, and we are assuming that some positive pressure, distending pressure is applicable at the alveolar level, but really nobody knows how much is that. So in pediatric patients, we usually start with the HFNC, but in the mild to moderate patients, I will not suggest you to start with the severe respiratory failure. It is most successful in the patients of bronchiolitis, but there is some reports of success available in patients with pneumonia, asthma, post-extubation respiratory failure, and pulmonary edema. Next. So non-invasive ventilation, we all are using for many years. Next. So we have standalone respiratory monitors. We have the conventional ventilators are also providing non-invasive mode in all the modern machines. And these are some of the indications: acute exacerbations of asthma, then hypoxic respiratory failure, community-acquired pneumonia. So it has been used. Remember, whenever we are using non-invasive methods of respiratory failure, very close monitoring is required, because it is very well proven in the literature then these modalities delay the intubation and the patient goes into a very severe problem. So whenever you're using non-invasive modes, whether HFNC or non-invasive ventilation, you should be you should be always ready with the intubation, and don't delay the intubation by just keep on saying that, okay, I'll wait for it. So any patient who has hemodynamic instability, who has neurological problem, lots of secretions are there's a bleeding in the mouth or in the upper airways, do not use non-invasive methods. Use invasive, intubate these patients. And few of the children will not accept the non-invasive method. They feel claustrophobic. So in such patients, this is another indication to start invasive ventilation. Next. So we use in acute care, and these are the different benefits of using non-invasive ventilation. It definitely reduces the need for endotracheal intubation. It reduces the rates of infection, shorten the ICU stay, shorten the hospital stay. It reduces the mortality, which is probably associated with the lung-induced injury induced by the invasive ventilation. It does provide some physiological benefits to the patient, less need for sedation. Now there are complications related with the interface that we use. So the interface should be very comfortable to the patient, but see to it there is no leak around the interface. Then we have to make sure that there is not distension of the abdomen. So the gastric distension is another complication. There is a slight risk, higher risk of aspiration or mucus plugging if the humidification is not all right in these patients. Next. So invasive ventilation, this is again a huge thing, but I will just say that the patient who has worsening pH or PCO2, the persistent tachypnea, a child who is on non-invasive ventilation should show you clinical improvement in next 2 to 3 hours. If the patient is not showing clinical improvement in next 2 to 3 hours and is getting hemodynamically unstable, his saturations are difficult to maintain, do not wait, kindly intubate the patient and start invasive ventilation. Next. Yes, the role of positive end expiratory pressure, we all know how it works, but it is an important parameter that we need to set, especially in patients who have atelectasis or who have VQ mismatching in cause of respiratory failure. So some degree of positive end expiratory pressure should be provided to all the patients, and then you need to titrate. So this is next. 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 Yeah. In ARDS, we all know these are the old definitions, but the ventilative support again we require that will again provide with the help of PEEP. We try to achieve rates to improve the pH to more than 7.2. We should try to use FiO2 to less than 40%. If there is a need, we should always be very comfortable with permissive hypoxemia and permissive hypercapnia. Remember, in a patient who has severe respiratory failure like ARDS, we are not trying to achieve normal blood gases. Our targets are different. We should always provide low tidal volume ventilation to these patients and try to maintain plateau pressure below 30 and the driving pressure, which is the difference between the plateau pressure and the total peak, that is less than 15, less than 15. These are the new parameters that we need to monitor for. Next. Refractory hypoxemia, we don't need to know the definition, but one of the oxygenation index is important parameter that we should keep monitoring in these patients. Next. I think we can skip this slide. We can go to next. Recruitment maneuvers. Recruitment maneuvers came with a bang few years back, but now no one is using recruitment maneuver. We are very comfortable with other modalities, other methods to recruit the lung, but some of the recruitment maneuvers, if you are using in your unit, you have to be extremely careful of the complications. The selection of patient has to be very important. You cannot use in patients who have cardiac dysfunction. Don't use neurologically deprived patients. Don't use the recruitment maneuver. And very few sustained inflation is the only method which has been studied in the pediatric patients. Next. So what we need to do, we need to increase the positive pressure to 30 to 40 centimeter for 30 to 40 seconds. Again, I am saying we are not using in our unit, and many units, level 3 units are not using in recruitment maneuver. We are comfortable with PEEP titration. We are very comfortable with the prone positioning. Next. We can skip this. We can go to next. Now these are again incremental PEEP titration, decremental PEEP titration, but many centers are using incremental PEEP titration. That is, you step by step you increase the PEEP, keep a very close watch on the driving pressure, the compliance, saturation, and the blood pressure of the patient. So you can monitor also the end tidal CO2 in these patients. So try to achieve a PEEP where you have the maximal compliance, acceptable saturation, acceptable end tidal CO2. Again, we are not targeting 97% saturation in these patients. Anything between 88 to 92 in these patients is acceptable with FiO2 less than 60%. Next. We can go to next slide. Next. Prone positioning. Now, many of us are getting very comfortable with the prone positioning in a patient who has severe hypoxemia or refractory hypoxemia. Early proning is beneficial to the patient. There are different mechanisms which have been enumerated for the benefits of prone positioning, like diaphragm movements, then the increased FRC, better VQ matching, better secretion clearance, anterior shift of the mediastinum, that is reduces the compression over the lungs. So, and reduced ventilator induced lung injuries. So what we need to understand that if you want to prone a patient, prone early, prone at least for 12 to 16 hours in 24 hours, don't prone for 5 hours. You will have benefits of prone seen in 5 to 6 hours. So that is important. So don't expect that the PO2s will improve very quickly. So that is very important, but you should always understand that there are certain contraindications also which are here on the slide, absolute contraindications and relative contraindications, but the unit has to be very comfortable. It is a laborious process, but with practice, with time, you will, after your learning curve, you will be very comfortable with the proning. Next. So this is what you see, the distribution of gases changes in the prone positioning in the prone positioning, and there is a redistribution of gases. As you know, the ARDS is a posterior lung disease. Dorsal areas are affected. With the prone positioning, you can see the recruitment has occurred. You can see better aeration of the lung even on the prone positioning. Next. So this is again this is a paper, landmark paper on the prone positioning in acute respiratory distress syndrome, and where they had shown the mortality benefits in these patients. Next. So this is, you can see the mortality benefit 32% against 16%. So there's a huge improvement in the outcome with the use of prone positioning. Next. Transpulmonary pressure directed ventilation. This is again it is not a mode, it is a technique of recruitment. And what we have in this is very briefly I will tell you that in transpulmonary directed mechanical ventilation, we are not only concerned about the alveolar compliance or the lung compliance, we are also concerned about the chest compliance. So in chest compliance, if you have the method to measure the chest compliance, remember, most of the critical patients have a lot of fluid retention or abdominal pressures are increased. So this all will reduce the chest compliance. So whenever we are titrating PEEP in the conventional method, we are ignoring the chest compliance. So in such situations, obese patient, obesity, then abdominal pressure increase or fluid retention, third spacing, dengue patients, in such patients, it is important not to ignore the chest compliance. Next. Next. So what we are doing, we are looking at the transpulmonary pressure. Transpulmonary pressure is alveoli and the pleural pressure difference. So that takes into account the chest compliance. So we insert a special catheter. Next. Insert a special catheter is inserted in the esophagus at the level of diaphragm, and that is inflated. The balloon is inflated, and the pressure changes in the balloon are reflective of the pleural pressure. So we get plateau pressure, TPT. We call transpulmonary plateau pressure, transpulmonary PEEP, and that is a different technique. You can read about it in some in some papers. Next. So transpulmonary pressure is actually the distending pressure of the lung, and it takes into account the lung as well as the chest compliance. That's what I have already told you. Next. So according to transpulmonary pressure, we set the tidal volume or we set the PEEP. Just go through this. There is nothing in this. These are just pictures. Dr. Oza, just go further. Go further. So this is the X-ray of the transpulmonary catheter, you can see. So in one of patient where we use the conventional methods of PEEP titration, we could go up to 8 or 10. But with the transpulmonary pressure we used, we could go up to the 16. So that was the best PEEP. So that is how you have a objective criteria to titrate the PEEP with the use of transpulmonary pressure. Next. So this is a landmark paper on the transpulmonary pressure, where though the mortality benefits were not there in the randomized study, but the PEEP titration was according to the esophageal pressure as well as according to the endpoint was the oxygenation. So there was a definite improvement in the oxygenation in the transpulmonary pressure group as compared to the conventional group. Next. Slides are not there. Dr. Oja, slides are not there.
Can you see the slides, sir?
Slides are missing.
Can you see now?
Yeah, I can see now.
Yeah, I can see now.
Okay, go further. Next slide. Next slide. Yeah, this is a slide where you can see the oxygenation benefit, the PEEP titration according to esophageal pressure, and there is a significant difference in the two groups. Next. You can skip this. Next. Okay, next. So here you can see the results. The 28-day mortality was not different. It was just 0.05. It is not significantly different in the two groups, but definitely the oxygenation was very significantly different in these two groups. So we still have larger studies to tell us about the mortality benefits. Now the next is the high frequency ventilation. Again, the indications that the mean airway pressures are more than 15. In a patient of ARDS, it is not recommended as an initial, but it is recommended as a rescue treatment. Pulmonary hypertension. So indications are inadequate oxygenation that cannot be safely treated, and then when the PEEP required, the plateau pressures are going high, FID requirements are more than 60% but unable to wean, and then the PEEP requirement is going above 10, oxygenation index is more than 14 or 15. These are the indications for the high frequency oscillation. Next. So the use of high frequency oscillation varies from unit to unit. There are some units, especially in the adults, they have totally discarded the high frequency oscillation ventilation, but in the pediatric units, still we are using the high frequency oscillation and we are quite comfortable. But again, I will say, if you want to use high frequency, recognize the time point when it should be started. If you start late, then it will not be helpful. A patient who has ventricular dysfunction, right or left ventricular dysfunction, this is not the modality to be started in these, but patient will collapse if you start this patient on high frequency oscillation. Next. This is another paper where that was totally against the high frequency oscillation. These are adult studies where there were no mortality benefit, and the one study showed higher mortality in the high frequency oscillation group. Next. Next. Pediatric literature is still open. We are still, as I said, the last word has yet not come, but there are many units where the high frequency is used, and the success depends on the recognition and the time of action. Next. Next. Yeah, INO again very occasionally used in patients in association with the HFO or in association with the conventional ventilator. You need a special setup, and basically this is a vasodilator, pulmonary vasodilator. You need to be careful with the use, and it has been most successful in neonates with the persistent pulmonary hypertension, PPHN, but it has not been very successful in patients with the ARDS. That is the population that we see in our PICU. Next. So this is the mechanism of action of the inhaled nitric oxide. It is basically vasodilator, and there is it leads because of the smooth muscle relaxation induced by this. Next. We can just run through these slides. The dosing is again different in the pediatric patients. It has been used very successfully. In ARDS patients, again, there is no difference in mortality in one of these studies. Next. We can go to next. We can go to next. Now we come to the ECMO. You must have been told about the use of ECMO in the respiratory failure. I will just enumerate the next. So these are the indications for ECMO in pediatric respiratory patients. the reversible respiratory failure not responding to maximal conventional therapy. I think this is the indication for considering ECMO. Again, FIPF ratios are there. OI is more than 40. Murray score, AI, hypercapnia, not responding to conventional treatment. And next. So the selection of patient is important. It should be started early before the patient goes into multi-organ dysfunction. So our experience is that whenever we have started ECMO for the respiratory indications, started early before the onset of respiratory multi-organ dysfunction, we had been successful almost more than 90% of times. But there are times when the patient had already had multi-organ dysfunction, primarily because of the respiratory causes. The indication, the success rate was less than 50%. So these are some indications in the neonates. Again, premature gestation more than 34 weeks, weight more than 2 kg, reversible lung disease, OI more than 35, and these are again acute deterioration or the rising rising PCO2s. Next. These are the definite out of neonates. This congenital diaphragmatic hernia, meconium aspiration, PPHN, the congenital diaphragmatic hernia and maximum success had been in these two indications, meconium aspiration and congenital diaphragmatic hernia. Next. So monitoring is extremely important in patients who are being managed for the respiratory failure, and you need to monitor the oxygen, you need to monitor the carbon dioxide, then periodic blood gases are required, you need to monitor the lung mechanics and respiratory drive of the patients. Only you can use NAVA, which is a modality available now in many centers. So this is again a very important and useful method to assess the diaphragm functions. Next. So this is what we have to do: improve oxygenation, and this is prone positioning. APRV you can use. This is a method that we used in patients with ARDS or refractory hypoxemia. Next. So these are certain the references which I have taken for the preparation of this presentation. Thank you so much. Sorry because of technical fault.
Thank you, sir.
Okay.
Nice presentation. Any questions to sir? If there are no questions, then we'll close the session.
Okay, thank you, sir.
Okay. Thank you.
Thank you, sir.
Thank you. Thank you.
Thank you, sir. It was a wonderful presentation and quite explanatory. All the slides were.
Thank you. So we'll close the session. Next, probably in the next week, I'll let you know the topics. Thanks to all.